Say good evening again. All right. Okay, I'd like to say again, thank you for inviting me to give this introduction lecture. This is one that I like to give every year to our residents because it's kind of a foundation for the other talks that we give on examination and diagnosis and anatomy and surgical techniques and so forth. But I'd like to start with this because this gives you a baseline. And just for an opener, I have a little TV commercial for you.
So, I use a CPAP too, and it's made a world of difference to me. But did you know that a dirty CPAP can make you sick? All that equipment is very germy. It's a perfect place for nasty stuff to sneak in, kind of like how I snuck into your home. That's why I use SoClean. Good night, everyone. Technology is kind of my thing. Please, Spock, do me a favor, and don't say it's fascinating. No. But it is interesting.
So this is not what we're going to be talking about, but does anybody have an answer to this question? No takers? Okay, so we'll just answer it for you. CPAP is the preferred treatment for obstructive sleep apnea, and got about 30% of people that fall in love with it, 30% that can't use it no matter what, and 30% that struggle with it. That's kind of rule of thumb. And you see the little asterisk, TNA is the preferred treatment for OSA in children. So goals for this lecture is to understand what sleep apnea is and why it is important, and how do we recognize it and diagnose it. So the outline will encompass definitions, prevalence of OSA, and then reasons why should we treat it. And then we'll review symptoms, risk factors, and comorbidities, and then talk a little bit about the sleep test, PSG. So when you're writing your diagnosis at the end of your notes, don't just say sleep apnea, say obstructive sleep apnea. It's more specific. Sometimes insurance companies get weird about that too. And then what is obstructive sleep apnea? It's one of a continuum in sleep disordered breathing, which encompass repeated episodes of pauses in breathing, which are called apneas, and decrements of airflow, which is not a complete obstruction, but these things disrupt sleep. And so on the bottom, you see snoring being on the left and obesity hypoventilation syndrome on the right, and sleep apnea is in the middle there. And so just for a note, the obesity hypoventilation syndrome, that's treated only with CPAP. Surgery does not correct it. It can make CPAP easier to use, but it will not correct it. So what is sleep apnea, obstructive apnea? It's when the airflow is decreased by 90% for 10 seconds. So that's key. And when it's decreased, there's a persistent respiratory effort. And then hypopnea is a decrement or a partial obstruction, but it's what I call a floating metric. According to Medicare, and that's one that probably most labs will use, airflow is decreased by 30%, at least 30% for 10 seconds. And desaturation during that obstruction has to be greater than 4%. And there's no arousal from a deeper to lighter stage of sleep. Now, with the American Academy of Sleep Medicine, their criteria was decreased airflow for more than 50% at a 10-second minimum, and a DSAT 3% with an arousal, or with an arousal, and Medicare just doesn't cover that. So primarily the one in yellow is the one we'll use. So there's also a respiratory effort-related arousal, which is called a RERA, and that's again a sequence of breaths, about 10 seconds or more, and there's increasing respiratory effort, and it ends when there's an arousal from a deeper to lighter stage of sleep. So it's a sleep disruptor. RERA doesn't meet criteria for apnea, and same effect as in apnea as far as sleepiness is concerned because it's a sleep disruptor. And many of these folks do not snore, up to 30% in the literature. I treated one who did snore last year. She was a 30-something girl, and the sleep study was negative for obstructive sleep apnea, but it showed that snoring caused a tremendous amount of arousals, and on a sleep endoscopy, it was snore from the tongue base. So we did a midline glossectomy on her. Snoring resolved, and her sleepiness resolved as well. So in regard to severity, this is important. Arbitrarily was divided into mild, moderate, and severe. So below 5 obstructive events per hour, you're in the normal range. 5 to 14 is called moderate, mild, and then 15 to 30, moderate, and severe is greater than 30. Now, some of these criteria are important because, for instance, if you do not have symptoms with a mild sleep apnea, many times CPAP or other treatment will not be covered. And then oral appliance therapy is FDA approved for mild to moderate sleep apnea, and severe it would be off-label use. And now in regard to AHI and RDI, AHI is the apnea-hypopnea index, and RDI is respiratory disturbance index. So the latter will include the RERAs, and sometimes they're just used interchangeably without that specific inclusion of RERAs. And so that's why AHI sometimes equals RDI. And as I mentioned before, to treat obstruction that's 5 to 14 events an hour, you need comorbidities in order to justify treatment. Well, you can treat it, but many insurance companies will not pay for that. And then the upper airway resistance syndrome, we just talked about. Symptoms can include excessive daytime sleepiness, any kind of cardiac disease, hypertension, and in kids, sometimes you'll have hyperactivity syndromes, learning decrements, and so forth, and even increase in seizures and seizure disorders. Treat sleep apnea in kids who have seizures, and sometimes seizures will resolve because it aggravates the seizure. So what is an obstructive apnea? Cessation of airflow for 10 seconds with continued respiratory effort. This is one page of a sleep study, which usually encompasses 600 to 700 pages. So this page is 30 seconds worth. And you can see the top 6 lines are the EEG, and then you have the eye movements, chin muscle tone, which REM sleep is measured on. Right and left tibial movements, anterior tibial, to check for periodic leg movement of sleep, EKG, snore, and then you have airflow, either checked by pressure transducer or a heat transducer, and then you have chest and abdominal movements. And so the circle encompasses that there's persistent chest or respiratory efforts while there's no airflow. And it should be pretty easy to see that. Now, central apnea means there's no respiratory effort, so all the lines are flat. And there are different reasons for that. A mixed apnea begins as a central apnea, but then when the person starts to attempt to, and so that's a mixed apnea, starts as a central. And then the hypopnea we talked about, 30 per second reduction, 4%. General population, and this is from nearly 30 years ago. This is a landmark study by Young, shows that 24% of men and 9% of women have obstructive sleep apnea by the definition of 5 or more obstructions an hour. And then when you add symptoms of sleepiness, it really decreases that substantially. And these are the people that need treatment. Now, 20 years later, we see a little bit of difference. I could not get exactly the same stats because there were 2 different studies, but overall you see it went from 24 to 26% with men, and then with sleepiness increased from 4% to 14% in men. So there was definite increase in sleep apnea and symptoms. And so we talk about prevalence, and it shows that we have substantial increase in prevalence in the last 2 decades. So this talk is a little bit old. I'm waiting for new data. Maybe it's out there and I haven't gotten it yet. But basically, it's increased because we as a country have increased in size obesity. And so prevalence of the mild to severe sleep disordered breathing in the overweight population, twofold higher in older men than in younger. And there may be several reasons for that. One may be that the average American male gains 10 pounds with each decade. Also, the activity is less, so the muscle tone is lower. Plus, we have a decrease in elasticity of tissues, and all those and perhaps other things combine to increase the prevalence in older adult males. Now, in women, when it says 5-fold higher in older women than in younger women, what we see is that women have a protective effect from the estrogen. And then after menopause, their rates increase similar to what it would be in men. And some of the older studies show that women who were on hormone replacement therapy actually had less obstructive sleep apnea prevalence than women who were not on hormone replacement therapy. But you know what happened with that? We generally don't use that anymore. I was just starting to look at putting women on hormone replacement when that study came out saying that it's no good, but that was a long time ago. So increased obesity leads to increased prevalence of OSA, and a 10% increase in weight gain, which for a 200-pound guy would be 220 pounds, have a 6-fold increased risk of moderate to severe sleep apnea, and a 32% increase in the apnea-hypopnea index. So why do we treat sleep apnea? That's from the combat casualty care course I did in Texas as an intern, so that's a long time ago. And why treat it? To increase long-term survival and improve quality of life. These are the 2 main reasons for treating sleep apnea. It has an impact on sleep, daytime function, and overall quality of life. Certainly, snoring can irritate relationships. A person can be very irritable, and I've had women tell me that since treatment, they're easier to live with. There is memory loss. You don't encode memory perhaps as good as if you didn't have that sleep lack. Morning headaches may be overblown, seeing more with obesity hypoventilation syndrome because that has to do more with a CO2 elevation rather than an oxygen decrement. Unrefreshing sleep, awakening, unrefreshed, daytime sleepiness. And these folks have been shown in a variety of studies to have a significantly increased risk of motor vehicle accidents, as well as workplace errors. There's frequent awakenings at night, frequent urination at night, especially in men, more than just prostate issues. And then focus, attention, and concentration have shown to be decreased. So these are some symptoms that people would have, not all of them, but some of them. And then GERD, perhaps 50% in the sleep apnea population. Hypertension is significant. Probably 40% of hypertensives have undocumented sleep apnea. Certainly coronary artery disease, atrial fibrillation. 50% of atrial fibrillation that does not convert is undiagnosed obstructive sleep apnea. Myocardial infarction, CVA. Had a friend a few years older than me, OBGYN, sleep apnea, was not my patient. Didn't believe in CPAP, went fishing with one of the surgical techs and had a stroke, cerebellar stroke. Took him a year to recover, get back to work. And then immune dysfunction, there's a lot of studies on that, and mortality. So we increase long-term survival, but did you know that the mortality is comparable to breast cancer and colon cancer? You know, nobody knows that, and we should know that. 38,000 die each year due to OSA. Okay, this is 10 years old. This data is 10 years old. Take a look at this next one here.
In 8 seasons with the Philadelphia Eagles, Reggie White played in 121 games and recorded 124 sacks.
So Reggie White, probably a little bit before your time, died due to obstructive sleep apnea. So couple more landmark studies, Wisconsin Sleep Cohort and the Brusselton Health Study. They have very long follow-ups, showed that the health risk was increased significantly with severe OSA. They were looking specifically at cardiovascular mortality as well. And so this is nothing to laugh about. Now, mild OSA, the data is not so good, but with moderate to severe, that's why treatment is covered. So quality of life, chronic fatigue. Now, if you look a little closer at it, chronic fatigue is not sleepiness. Somebody with chronic fatigue or being tired, quote unquote, they can sit down in a chair or lay down and they'll not fall asleep. But somebody with sleepiness will fall asleep in those situations, and that's why we use the Epworth Sleepiness Scale. Poor job in school performance, and when they looked at kids in the bottom quartile of school, they showed that there was a much higher percentage of obstructive sleep apnea in those kids. And then social consequences, sleeping in separate bedrooms than your spouse, snoring that is that significant, most likely 90% plus is obstructive sleep apnea. And then impotence, nobody talks about that, everybody gets Viagra. And then I get a lot of people feel like they're aging early, and then after treatment, they feel like 10, 20 years younger. So that's very gratifying when they tell you that. So OSA can cause or exacerbate cardiovascular disease, diabetes. Diabetes control gets better with treatment, especially for the non-insulin dependent ones. Hypertension. I've had hypertensive patients go down from 2 or 3 to 1 medication or on 1 medication reduced dose. I remember even one lady was getting hypotensive and needed to go off her medication. Depression is a major side effect in many people. Certainly can aggravate asthma, and we talked about stroke and so forth. Drowsy driving is a big deal, actually. So we talked about relationships and poor performance. And as far as drowsiness with driving, same risk as drunk drivers, 0.9 alcohol level in the blood, and indeed cause more accidents than drunk drivers. And less than 6 hours of sleep, which sometimes is a resident thing, affects reaction time and judgment. But now they have resident hours, so maybe that helps. So risk factors, obesity, we talked about, craniofacial disorders, that's Dr. Carr can talk about that a little more. Retroposed mandible or maxilla. Bony structures are small, so it's not all soft tissue. Of course, adenotonsillar hypertrophy. Endocrine. Had one lady with hypothyroidism. I took a history and it just suggested that she was hypothyroid. She was cold all the time, couldn't get warm. So I did a thyroid function test on her, and her TSH was like 125. I tried for 6 weeks to get her on thyroid hormone, but she just wanted sleep apnea surgery. Finally, we got her on it, and her sleep apnea resolved. And then postmenopause, we talked about. Polycystic ovarian syndrome, they don't all have obstructive sleep apnea, but it's a risk factor. And then for reasons that we don't know much about genetically, could be facial structure as well as other things, family aggregation. There could be decreased reflexes in the upper airway, but that's under study right now. So I guess this is where we're going. Probably like that cartoon where they're all on that spaceship and they're just getting heavier and heavier with each generation. So obesity reaches epidemic proportions. And this was, again, it's about 10 years ago. And there was a goal set to achieve decreasing obesity to 15%, but it didn't work. West Virginia, where I live, it's just, we're an obese state. So take a look at this over the next 30 seconds. This is Obesity Trends. And West Virginia and Mississippi go back and forth for being #1 in obesity. But some states are not too far behind. I guess Colorado would be the healthiest state. And if things continue how they are in another 10 years, well, we can see 60% obesity in 13 states. I guess we would be one of them. And all states could have rates above 44%. So almost half the people in every state will be obese. That's incredible. I guess That's the way it is. In Mississippi and Colorado, those are just opposite ends of the expectation. So this is a article I found in JAMA about 10 years ago that when I was going to school, they talked about the standard 70-kilogram man. But this article said that it was outdated and should be probably the average 80-kilogram person. But I digress. So this is the look of the future here. Now, this was an interesting article, again, about 10 years old. It's a high-risk population. There was the Comprehensive Wound Center, Ohio State University, with people who have chronic non-healing wounds. You know, a lot of them, they give not bariatric, what am I trying to think of, where hyperbaric treatment. And but 50 of these underwent home sleep studies, and they found 50% prevalence of obstructive sleep apnea. So more than 2-3 times the national rate. Cardiovascular disease, we talked about this, mood disorders, depression, irritability, and so forth. So hypertension has a high yield. Everyone with hypertension should be evaluated for obstructive sleep apnea. That's what I tell the family practice doctors when they've invited me for lectures. Resistant hypertension, those with 2 to 3 antihypertensive medications, 77% prevalence. And cardiovascular disease, you go to cardiologist office, 40% have undiagnosed obstructive sleep apnea. And then nocturnal GERD, have to consider that. I just had a lady this afternoon with mild sleep apnea and taking Nexium in the morning, but having a lot of GERD problems at night, even lying in an elevated position. So I just had her switch to a before dinner Nexium instead of before breakfast, because if you take Nexium at night, it doesn't work at bedtime. The H2 blockers will work at night. But we've set her up for oral appliance therapy. And now to the PSG. So a lot of times these were in the hospital, and more we're getting to freestanding sleep centers. We have a sleep center with 10 beds. So it's kind of like a hotel room, private bath, TV up on the wall on the right, and beds to accommodate even the mega obese. This is not one of those. So for sleep studies, there are 4 levels of sleep studies. The level 1 is the standard in-lab sleep study. And level 2 is the same parameters as in-lab. They're just going to a nursing home or somewhere else. A tech is going and doing the whole test, but that's rarely done anymore. Level 3 is the home study, basically has 4 channels and just looks at sleep apnea. It doesn't look at any of the other things an in-lab study would look at, like seizure disorder, REM behavior disorder, and so forth. Level 4 is a home study, basically that's a sat monitor, overnight sat monitor, recorded sat monitor, and which is not really helpful for diagnosing obstructive sleep apnea. And if it's positive, then you still need a sleep test. So this is a PSG. We saw one earlier with the obstruction. So 30-minute or 30-second epoch, and you can see the chest and the abdomen and airflow moving up and down. So PSG will look at the heart rate, the electroencephalography. EOG is electrooculography. It looks at eye movements because eye movements are necessary to diagnose REM sleep. EMG, the chin EMG, during REM sleep, tone goes away. You have no muscle tone to speak of, because if you did, you'd be getting up and acting out your dreams, and that would be dangerous. So when you have EMG, also looks on the lower legs for tibial muscle movements. Oximetry, of course, snoring. There is a microphone, nasal and oral airflow, and respiratory effort with the chest and abdominal sensors. So what we're looking at is sleep efficiency. How much of the night is somebody actually asleep as opposed to being awake? Sleep latency, lights off to sleep onset, REM latency, sleep onset to first REM, EKG, of course, periodic leg or limb movement. Could be upper limbs as well, but we look at the lower limbs. Sleep fragmentation, that's a big issue as far as sleepiness. And then sleep architecture, how do the sleep stages show up over the night, and respiratory summary. So again, we're looking at the apnea hypopnea index or the respiratory disturbance index and minimal oxygen saturation. And the sleep studies will come in a variety of forms. You know, I've been doing this for years, and sometimes I'll see some study come in from elsewhere, and it takes me a little while to kind of move through it to see where I need to go. In this particular one, which is not our lab, it shows that in the upper right, you have the oximetry data with the mean saturation, which I don't typically look at, but the lowest saturation. And now we're looking at time spent under 88%, and because that can impact health for sure. And then you see arousal data just below that, number of arousals, and then spontaneous arousals. And if it has a reason, they indicate what the reason is, whether it's leg movement or snoring. And then before you walk in the room, somebody has a sleep study, should be on your record, hopefully, that can look at the respiratory summary, sleep architecture, limb movements, and fragmentation, just to get a feel for what's going on with them. And then sleep stages, there's 3 stages, and REM stage. And stage 1 is basically when you're falling asleep. It's about 5–10% of your sleep time. And if you're snoring and somebody shakes you on the shoulder, says you're snoring, you say, no, I'm not, I'm awake. So that's kind of in between stage. Hypnogram kind of is a graph that shows where these cycles occur. Sleep efficiency, we talked about normal is 85% of the night you're in sleep, and then sleep latency. Usually it's under 20 minutes. REM latency, about an hour and a half. If it's shorter than that, say if it's 60 minutes, that could be a diagnostic sign for depression, or if it's within 15 minutes, that could be narcolepsy. So these are things you look at. And here just what we talked about. Okay, and then, we're looking at the obstructions during REM and non-REM. Usually, but not all the time, REM AHI is worse than non-REM AHI. That's because muscle tone goes away. And some sleep studies will show that there is no REM for a variety of reasons. They could be on REM suppressing drugs, or just before they get into REM, they obstruct, so they never get there. I've had people start dreaming again right after treatment, and that's pretty common. So we're looking at the minimum oxygen saturation, which can be LSAT, lowest saturation, or oxygen nadir, and then time spent below 88%. And then positional. I think this is important, but not all the home studies we get actually show this. I like the one we have at WVU because it shows supine versus non-supine. Sometimes positional therapy is what's needed, and there are positional devices you can use to train yourself to sleep in a non-supine position. So excessive daytime sleepiness, they might have periodic leg movement at night, and this can cause significant sleepiness because of arousals, but there's no significant numbers of apneas. It can only be diagnosed with a sleep study. Now, restless leg syndrome is something that's clinically diagnosed in the chair when you're talking to the patient, because there's no study for that. They'll just give you the symptoms. Now, in many cases, they can have both, but it's not a direct one-to-one. And then restless leg syndrome, as I said, is made clinically. Urge to move the legs, kind of preventing them from falling asleep. But periodic leg movement disorder, it will give them multiple arousals and then interfere with the partner's sleep many times. So all the sleep studies will have an arousal index. We mentioned that. And sometimes this can be treated. If you treat the periodic leg movement disorder, then their sleepiness goes away. Any pain disorder, such as fibromyalgia, can give them arousals. Alpha intrusion is just something that's read on a sleep study by the sleep technician, and 3 seconds associated with pain many times. So indications for a PSG, diagnosis of a suspected sleep breathing disorder. CPAP titration. Now they have AutoPAP at home. I'm not real keen on those because you just mail it to the patient, have them put it on. I think they need a little bit more education than that. Pre-op evaluation for snoring patients. You just don't operate on snoring. You want to make sure that snoring is not the tip of the iceberg for sleep apnea. And then, you can assess treatment with oral appliance, get a post-op sleep study, make sure that you got the improvement you're looking after. Or if they are initially cured and have recurrent symptoms, repeat a sleep study. Or if there's been more than a 15% change in weight, then repeat a sleep study. So other indications, you can look at narcolepsy, periodic leg movement, sleep, and the elderly have a higher rate of this, and so that might be an issue to consider. I know on your boards and in-services, they talk about some of these things, which I didn't think they would, but they also talk about drugs to use for different other sleep disorders, and sometimes you need to know that to pass the test. Anyway, coming on the final direction, this is in Oxford, England. I just thought it was a neat picture. So, given tickets. Goals and metrics. The polysomnogram is not the only measure to measure treatment success, because it doesn't capture everything. There have been other studies that are done, simulated driving tests and so forth, that show that people do improve with that, even though maybe the apnea-hypopnea index doesn't change. So it shouldn't be used exclusively to evaluate your treatment response. And other available metrics, the morbidity for cardiovascular disease. Excessive sleepiness can improve. I've had this many times. They're not as sleepy, even though maybe the AHI is about the same. MVAs have been shown to be less frequent following treatment when the PSG doesn't change. And then they looked at other physiologic and metabolic parameters such as immunity and so forth. Certainly you can have improvement in snoring without any change in PSG parameters. So those are some of our metrics. And one thing you really need to know is there's not a one-to-one correlation of sleepiness with sleep apnea severity. You can have some people that have severe sleep apnea and are just fine. Others that have very mild sleep apnea, say with an apnea-hypopnea index or 6 or 8, and they're just devastated by it. So as I said there's clearly differential susceptibility to sleepiness. Now you got to be careful, because many times with the guys, they will push through or work through their sleepiness. And some are very driven, and they can do this, but you leave them alone and then they fall asleep. Then interestingly, I don't know how much you guys do UPPs. There's about 6 variations of it, but back in 95, when this study was done, they did driving tests, and with those that had no change on the PSG, they still improved, which I mentioned just a couple slides before. And then psychomotor vigilance tests, those are tests when you're in front of a computer responding to their specific regimens. So again, they didn't fail treatment, but it's not reflected on the PSG. So this is just what you got to keep in mind, even though we are trying to get the apnea index down. So keep in mind the goals of treating sleep apnea: increase survival and improve quality of life. But patients come to us because they want to improve quality of life. And so they're not always so interested or even know about long-term survival. So we increase their survival, we improve secondary measures, and just remember that nothing is written in stone, but things are still written. We gotta know what they are. And that concludes this presentation. So I'm ready for questions.
Thank you, Dr. Coutras. If you guys have any questions, just feel free to unmute yourself.
Doesn't look like there's many questions.
I guess for starting your sleep fellowship, I would assume that you kind of work very closely with your sleep medicine colleagues. Um,
Oh yeah,
are you sending a
yeah.
lot?
So I would say there's 5 of us in the sleep medicine department. There's me from ENT. We have Dr. Stansberry, who's pulmonary critical care. We have a neurologist. We have pediatric sleep medicine, and we even refer to sleep dental colleagues here at the university who deal with primarily oral appliances, although I fit those myself as well. And we're continually sending people back and forth. We've done presentations together. Stansberry and I go to the American Academy of Sleep Medicine and provide a course on treatment of sleep apnea from anatomy perspective. And Strollo comes to talk about the inspire characteristics, and I'll do a segment on anatomy of sleep apnea. And these are for our general sleep medicine colleagues. So at least here, I'm happy to say we're a tightly knit group and work very well together. And I don't know if you were all there when I mentioned that our sleep fellowship is kind of a hybrid fellowship. So this year we're starting with internal medicine grad, but certainly we'd be open to ENT applicants in the future, and 20% will be sleep surgery. And for the internal medicine grad, I'll be spending 2 days a week, 3 months for the next 3 months with him. And one of those days will be in surgery, so he can observe what we're doing.
Oh, cool. How often are the patients using CPAP after they get surgery and they're still feeling symptomatic, or they still have residual OSA?
Well, 75% of OSA patients are going to have multi-level obstruction. And generally, at least from my perspective, is not to treat all the levels at once. Sometimes it may be more than what they need. For instance, you can do one level of surgery, say, if you're treating the palate, and then suddenly the base of tongue is not a problem anymore for a variety of reasons. But if you try to do everything at once, according to the Stanford protocol, that's a big hit. And instead of going home the next day, because I keep them overnight, they might stay in the hospital for 4 or 5 days just recovering, and then swallowing after a multi-level procedure is just horrendous for months. So I tend not to go that way. After the initial surgery, we get a repeat home study, see where we are. And then that may make them a candidate for an oral appliance if they have teeth. And they have always offer them to have another trial at CPAP, and some of them will just go and be able to use CPAP. Sometimes you can, especially with tongue-based surgeries, you can reduce the CPAP pressure from, say, 20, 22 down to 10 or 12 and make it much more tolerable for them with less leaks, and they'll go with that. And I have a few patients that have combo treatment, oral appliance after surgery, or oral appliance that suddenly or gradually failed to treat all their problems, so we did a surgical procedure that allowed them to improve. Does that make sense?
Yeah. For your patients that you keep overnight, do you use a CPAP? So if you do a UPPP, do your patients get a CPAP overnight if they're still using it?
Yeah, yeah. Many times they will, because I think it helps swelling go down, and then we see how they do with the CPAP. But other times we'll have them monitored for continuous pulse oximetry, and if they maintain a SAT above 88, then that means they've done much better, and we can safely send them home on narcotics.
Okay. Because I know we have some attendings that are concerned with starting a CPAP, mostly after tonsillectomy, with concern of possible bleeding. Is that the case for you as well, or?
You mean a straight tonsillectomy, or sewing pillars shut, or?
I guess tonsillectomy with or without the UPPP.
Yeah, I guess I could see some concern. I've not ever had a problem, you know, maybe that's good fortune. But I try to go ahead and sew all the pillars with double layer closure. And I try to keep the pressures down 12 or under. And they'll usually put BiPAP on when we order it.
Okay.
All right. So, you know, when you guys get together and talk about it, let me know if this was too much or if there were areas that you think needed a little bit more attention. And, you know, if this is something that you're interested, we can do some more things.
Thank you. This was great.
Thank you.
All right, guys. It's good to see you all. I wish you well, and I'm going to go ahead and sign off.
All right. Have a good day.